Hello, welcome everybody. As we mentioned, there's a chat on the side. Please feel free to write down your name and where you're tuning in from. It's always so exciting to see where everybody is coming from and watching and what they're doing. So please feel free to do that at any time. Welcome everybody. Happy New Year and welcome to Maternal and Infant Canada's first educational seminar series for 2022. Maternal and Infant Health Canada, also known as MICAN, is a global public health organization devoted towards improving the lives of women, children, youth, and the environment through education, research, and innovation. We are comprised of doctors, researchers, public health professionals, and traditional practitioners from around the world. And I can hardly believe it, but I think we are now on our third year of providing these free international webinars. So that is pretty exciting. We've had speakers and contributors from almost every single continent. And we really do hope to continue to amplify and connect to these voices of change. To learn more about our work, I'm going to actually just put something quickly into our chat box here. There we go. To learn more about our work or to become a speaker, a researcher, or contributor, please email us. And I've put this all in the chat box now. So mycancares@gmail.com, or you can follow our Facebook page, which I've also added in there. If you'd like to catch up on one of our previous webinars, we have many really interesting topics. You can go to our website, which is maa.med.ubc.ca. Again, it's on the chat box. So maa.med.ubc.ca. And then you just click on the education tab followed by the webinar tab. As usual, I am your moderator, Dr. Emily Solomons. I'm a doctor of traditional Chinese medicine, and I have been a team lead for Maternal and Infant Health Canada for the past 7 years. I am zooming in from the ancestral unceded territories of the Kakite and Coquitlam Nations, here also known as New Westminster, which is near Vancouver, Canada. Before I introduce our esteemed presenter, Dr. Giulietta Cavattuna today, I would like to first extend a few big thank yous. So first, I'd like to thank Parisa Kabir for organizing the event. Thank you, amazing. And the fabulous Healthy Seminars who have been donating their platform since the beginning. And so once again, we really, really thank them for that. I'd also like to introduce Dr. Farah Shroff, who is both the founder and lead of Maternal and Infant Health Canada, as well as a current Takemi Fellow at Harvard University. Dr. Shroff, one of our innovations is to link natural systems of health promotion and disease prevention to the global community. Do you think you could give us a brief highlight of maybe some of the current projects that MICAN is involved in right now, and then we'll get to our main lecture of the day?
One of our studies is on Ayurveda and yoga in India to reduce the deaths of women and children. 1 million babies die before their first birthday in India. So we're trying to see what we can do using traditional extant systems of health promotion and disease prevention that exist within India with that study. And then the other study, which we are just putting the finishing touches on the first manuscript right now, is called the COVID Catalyst Study, which is looking at how to improve the lives of women through health policies. It's a global study. So I won't take any more time from the wonderful Dr. Giulietta. Thank you.
Thank you, Dr. Shroff. So with no further ado, today's webinar is on a special maternal and infant health topic. Our presenter is the Honorable Dr. Giulietta Cavattuna. She has spent more than 13 years as a parliamentarian, where she was politically assigned for 5-year terms as Deputy Minister of the Ministry of Youth, Ministry of Health and Social Services. And during her tenure in the Ministry of Youth, she launched a campaign, Operation Hope, which successfully inspired hundreds of unemployed young people to identify their needs and pave own ways to take up studies and create their own employment. She's been a community activist her entire life. Her activism is centered on the promotion of gender equity and the provision of quality healthcare for all, especially in the areas of mental health. As with all of our public webinars, I do have to say the following disclaimer. This course and handouts may contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. If you have any questions during this webinar, please, the chat group that we've been introducing ourselves in, feel free throughout the lecture to put those questions in the chat box. And what I'll do is I'll be capturing them throughout. If there's something that needs a correction immediately, we can do that then. But if there's anything else, what we'll do is I'll capture everything, and at the very end, we'll have an open discussion where we'll be able to go through all of those questions. So without further ado, I'm going to pass it on to you. So let me just pass this on to Dr. Kapituner.
Yes, good afternoon. It's evening here in Namibia, and good morning to you all who are coming on board. I'm really delighted for the opportunity, and thank you very much, Dr. Farah, for giving me this opportunity, for getting in touch with me, and we started communicating on this very, very important aspect of healthcare. So my presentation, I was given an hour, but I think I will capitalize on using some few minutes in order for me to get more questions from the presentations. So my presentation is actually based, the content, it's the title is Maternal Mental Health Matter. And the content of my presentation is a brief introduction about Namibia. I heard that many people do not know Namibia, so I will introduce Namibia to you this evening, this morning. The status of healthcare, just in brief, what Namibia healthcare is looking like, the maternal health in general, the maternal mental health importance, type of mental health, and then how this condition affect the maternal health in general also. And then very important in integration of maternal health in perinatal care. It's a South African model that we are currently using at our center here in Namibia. So the very important Namibia, that red country there, it's at the southwest of Africa. It's we call ourselves the big small country because we are a big country of 885 square kilometers, and we have a population of 2.4 million, which is actually everybody. It's occupying three square kilometers. If you scattered us all over the country, we got our independence in 1990. We have our third president. And our healthcare system have been evolving from being more curative to a more preventative, though it's a very slow path. Then our life expectancy in the 1990, it was around 65 for women and 58 for men, and now currently we are standing around 78 women and 65 men, and this is the anticipated life expectancy by 2100, and I hope that we will really come to that. The next issue is that how well is the country or territory providing effective and essential services? We were here at 43%. We moved to 49%. And we are standing at 62% now. This is the latest information. And very important in our healthcare, we do not have the universal healthcare coverage per se, but the services are given free of charge to the Namibian people. 83% of the Namibians depend on the state, and we are giving them free of charge healthcare, and they only pay a quarter of a US in order to get all services, even specialized services like oncology, surgery, and they usually make a joke that you only pay a quarter of a dollar from where you come from until you go to the mortuary. So they said, if you are not making it, but the services are free of charge. Then we have I'm going to look at how is health spending allocated among treatment, prevention, and activity. You can see outpatient is the biggest chunk because the inpatient curative care is the biggest chunk. It takes 35%, and then the outpatient curative care it's taking nearly 25%. With other services taking 9% of the whole chunk of the resources that is allocated. We are one of the African countries that are domestically funded. Our budget is 97% of our own domestic resources, excluding the programs that we are getting from the US, the PEPFAR program for HIV and malaria programs, but all the other resources are coming out of our own coffers as a government. Then which diseases and health conditions does Namibia spend on? We can see that it's spending a mass, what is this now? Excuse me, please. It's spending a massive 25% on infectious and parasitic diseases, 22% for reproductive health, and 14% for non-disease specific, and 9% and 1% on nutritional deficiency. It's how it's spending the resources that we are having. The next thing is that maternal health in Namibia, the third sustainable development goal is to ensure that we are promoting well-being of all at all ages. It is to reduce the maternal mortality to 70 per 100,000 live births by 2030. And Namibia have reduced, we were at a massive 412 before the end of the Millennium Development Goals, and we reduced our maternal mortality to 190. So we're still optimistic that we are capable to reach the 70 per 100,000 beds by 2030, because the efforts that the government is putting in, it's really commendable. We have a 19.1 neonatal death per 100,000 beds, live beds. We have 30.7 infant deaths. And then antenatal care enrollment stands at 97%, and 96 of the people that are attending antenatal care, they are being enrolled for PMTCT, prevention to mothers, prevention to mother to child prevention. And then the facility delivery had increased. We have known that we had traditional birth attendants and many people did not come to the clinic, but with this 97%, you can see that many of them, around 89%, come to the facilities, whether it's a clinic or a hospital, to deliver. And especially complicated cases are currently mostly being delivered at the health facility. So why is maternal mental health important to us? I think from the impaired cognitive function to conduct disorders, depression and anxiety, and learning can lead to a lot of learning disorders. Maternal health can impact in long term of the well-being of the child. So you don't want to get a child that is actually vulnerable because the mother did not get treatment for maternal health, for maternal mental health. So it's very, very important that we secure the mother and the child, because there is so many things that can happen to the child if the mother is not well. Then the factors that contribute, and this is specifically to our environment, and it's a previous experiences of mental health problems, its biological causes, lack of support, especially in our country. We have so many extramarital or before marriage children born out of wedlock. So the lack of support is basically one of the major things that we are dealing with. Difficult in childhood experience, experiences of abuse, gender-based violence in our country. It's also one of the highest recorded countries with gender-based violence following South Africa in Africa. So there is a lot of gender-based abuse, especially against women. Low self-esteem, stressful living conditions because of poverty, and multiple of children that our people might have. It is always difficult to have the ends meet, and it stresses the mother when she is pregnant, and it can contribute to anything. Unemployment, poverty, lack of sanitation, all these kind of things are actually contributing. And major life events like any other, you might have lost a partner, or it could have been that you lost a child before. So it can also be a contributing factor. So this is actually the major causes of factors that might contribute or aggravate the issue of maternal mental health. And then the types that are lingering on our heads and that are very, very prominent in our community is the postpartum depression, dysthymia, persistent depression disorders, pregnancy, postpartum general anxiety, because of things that might have happened. One will always be anxious, even if it's an abortion or a miscarriage or whatever, it can create a lot of anxiety. Pregnancy and postpartum general OCD, and then the birth-related post-traumatic stress disorder is also one of the major things, because unfortunately, when you become pregnant, many people will not really expect what they feel during pregnancy because of what they have gone through before. We have a lot of rape cases and other issues. Things that you might not know about postpartum depression, that 80% of women that are delivering suffers from baby blues. That's a reality. 15% of women suffer from postpartum depression, and 8% of men also are affected by the conditions. There are a lot of sleepless nights that cause depression, and the commonly begins between the week and shortly after delivery. So this is the kind of situation that the postpartum depression have results on, and as many people are really going through these processes and or difficulties. Yeah, how is these conditions affecting women? As I have said, that every situation or every condition or disorder that we have aligned, it's having a specific consequences for the mother or the father. Sometimes you even could hear that 8% of men are also affected by the postpartum. So it's a mother and father issue mostly, but mostly affected, it's the mother. Depression and anxiety. Sorry, I think my computer is very fast. Depression and anxiety are the most common diseases. It's health conditions, mental health conditions, and it's affecting 12 to 13 people, and depression and anxiety combined also can also affect 15 to 20 women, percent of women. Acute psychosis in pregnancy is an obstetric emergency. And no, in our cases, we never had it that somebody was brought to the facility and it had been treated as an emergency. Nobody really have time to realize. Maybe they will say the mother is absolutely in a difficult condition. She must be drugged in order for her to relax, but it's an emergency. It's an obstetric emergency. For about 1 in 4 women with post-traumatic stress disorder, the opposite is true, that they will never have a pregnancy that is peaceful and actually more enjoyed like what it's supposed to be, because there is so many things. The child that she's carrying is because of rape or something, so there is a lot of issues that goes with this. The research have listed an association between postpartum depression and delayed in the development of the language, disorganized or insecure attachment, high rates of behavior, or especially for children that are born by mothers with this condition. So research have shown that there is really a linkage between these two. The next thing is the maternal mental health, and this is actually a booklet. It's a handbook from the Perinatal Mental Health Project in Cape Town. And I have really to compliment and give credit to this project, because it has opened avenues that were never found. Because in South Africa, they have managed to integrate, especially in the Western Cape, they have managed to integrate maternal mental health into the antenatal care. What happens there is that this is an independent project. The perinatal care is an independent project that is based at the University of Cape Town, successfully integrated the healthcare in the perinatal maternal health in health facilities, especially for antenatal care. The mental health assessment is being done by trained non-professional professional public health that are people that are trained by the Public Health Institute of Namibia, because we also now have also come in and start training our own, but these ones are trained in South Africa. So what happened is that because the nurses are overworked, because of the priorities of diseases, overlapping priorities, they don't have time really to deal with social issues while they are also having their own social issues. So in order for us to have a very productive, we actually train these people in layman counseling, and also just to complete the form if the person is not ready to complete the form on their own. So the routine screening is actually starting at 2 weeks, where the women, when you come for antenatal care, and it's free of charge, nobody is paying, even in South Africa, the project itself. So we actually copy the whole model, and we actually also just do what they are doing, because they are not, nobody is paying for antenatal care in our country, so you cannot come and ask for a few cents additional to what these people are doing. So we are building partnership with the public service and also civil society in order for us to enhance the involvement of women and men when it's coming to maternal mental health. This is actually the instrument that they are using, the Edinburgh Postnatal Depression Scale. That is what is used. So all these questions are asked to the woman, how you are feeling or whatever. I have been able to see the funny side of things. So they actually just marked why they are falling, and then you can see what is the underlying factors there. And then also we have a risk factors assessment. It's another form that is also been completed, where we ask specific questions like, I feel pleased about being pregnant, having had a baby or something like that. So it's also a risk factor to know that, okay, if somebody is not happy about a baby, something could be wrong. Either it's a social issue or it's a maternal issue that need our attention. So these scales are actually, these forms are at the end of the consultation. We are calculating it, and anything below 10 from the answers that they have given, it shows that there is no mental health or suspected mental health, and you just give them an encouragement, a health education, and you let them go. Above 10, you can actually know that there is a risk of depression or anxiety, and you need to do some referral, whether it's for counseling in this case. But when it's above 13, then the woman needs a referral to a psychiatric, because to the psychiatric center, the mental health center, in order for her to get more attention, because there are also some red flags coming about her condition and her situation. And then there are also immediate questions, because sometimes there is no time and one comes in the facility, but you see this person is not in the mood of talking. You just ask 3 questions, basically, not to take a lot of time. Just like, for instance, in the last 2 weeks, have you on some or most days felt unable to stop worrying about or thinking too much? And then the other 2 questions, when it's a 1, then you just give encouragement. And when it's a 2, you actually offer counseling, and the person will be requested to accept the counseling or to reject the counseling. But when it's a 3 out of 3, then you refer immediately, or you can make a follow-up in order for you to have a discussion in that regard. So yeah, and basically that's actually what is happening. And the Public Health Institute of Namibia, it's our baby that we have actually been in existence since 2020. So it was like, it worked in 3 areas. One is research and consultancy. It's a mental health, then mental health. Currently we are running actually 3 projects. One is on the well-being of, or wellness and well-being of the health professionals after and during the COVID pandemic. So we are giving counseling, we are giving relaxation therapies, we are giving yoga. So that is one project. And the other one is the maternal mental health that we are currently running. And the next one, the last one, it's the mental health, community mental health. This model, we are actually going to communities because of the stigma and discrimination that is existing within the mental fraternity. What we do is that we have support people that we recruit. When a person is diagnosed with one or two mental conditions, then we recruit support people. These people will be there to give guidance in terms of when to go for follow-up, when the person is having an episode, so that you cannot just run alone to the hospital, but there is somebody who does that. So community members, and some of them, they don't even have people that are having mental condition, but they support the group in order for them to give support to the people that with mental health, with mental illness, in order for them to continue and not breaking their medications, or not to what is the term? Not to be able to stop their medication while they need to get a proper care. So that is the 3 projects that we are currently running. And the third component of our public institute is women health. Anything from prevention, from screening of cervical cancer, from immunization and vaccination. We're actually doing it also at our institute. So this is basically what I wanted to present. And I would like to say no women should die while giving a life. That's the main component in the corner. And this is just few phrases in Namibian vernaculars to say thank you. Ondapantula, okuhepa, kai oes, lutumesi, pandu, and baya danke. So that's really what I wanted to share with you this afternoon. And I'm open for questions, please.
Oh, well, I want to have my try at some of these. Well, I can go with Pandu. That was nice. Go with the easiest one first. Okuhepa. Yay, okay. All right, so we have a few questions that have come in, but I'd like to ask everybody else, feel free to go to the chat and start putting some questions in there. So as I start, we'll get to yours as well. So the first question, excuse me, is right from the beginning of the lecture. Can you tell us about how Namibia achieved universal healthcare coverage? I mean, 25 cents for primary care is very affordable. We often hear that this is not something that's possible. So we want to hear how Namibia was able to do this because it is phenomenal.
Yeah, thank you very much, Dr. Emily, for that question. When we got our independence, we immediately identified some important factors that we like to top our agenda in 1990. It was free education, free healthcare services, and housing. In the two, and I think health have actually become the most important one because it has been the quarter US dollar, it have actually just increased in 2021. The whole time it was a 10 cent in US dollars terms. So that was actually what we have. It's not so quality, more like the healthcare, it's not really the top notch, but we actually give healthcare from the low level. We have actually 5 levels of care. It's a community health worker that goes in the community just to observe the malnutrition, the non-immunization, pregnant women, and report it back. And then we have outreach programs where a nurse is actually visiting the country. And then we have a clinic, we have a health center, we have a district hospital and level 1 hospital. So when you pay at the clinic, you go through until level 1 hospital without putting up another cent. So I think it's just a political willingness that have been taking the decision from the onset, and it have been kept so well. Thank you.
Thank you. And I mean, it's inspiring. I think it's really, it's always so good to see countries doing this. We actually had a question. Al-Hadi, you wrote a question. Did you want to ask that in person? You can actually now unmute. I think you can unmute yourself. If not, I will ask. Oh, here we go.
Dr. Al-Hadi.
There we go. I've asked. There we go.
Thank you. Good time. Good morning for you. Special thanks for Jolita for the sermons and Prof. Sharof. How are you? Fine. It is very interesting to attend this wonderful presentation. Really, I am very interested of your talk, Victoria Jolita. My question, if there is any specific scale for prediction of postpartum depression during antenatal care, can you advise for any specific scale? This is my question, and thank you very much. I'm so happy to be a part of wonderful event. Thank you.
Yeah, thank you, Alette. I think there are two scales. The Edinburgh scale that I have shown, it's one of that. And it's actually always, I actually forgot to put the link of the perinatal project in South Africa. It's available. It was funded by an African Mental Health Institute that funded that project, and it's actually available for anybody else who is trying to lead into maternal mental health. So the link, it's I might share it later, or maybe if we can just go through and just see at the perinatal health perinatal mental health project in Cape Town in South Africa at the university. So they have that as an Eden-based scale. And the Eden-based scale is more focused on the postpartum issue, while the risk factors is actually determining whether the woman is at risk or not. So I think it's available and it can be shared so that everybody who wants to modify and to use it for the benefit of the community in your area of jurisdiction can be able to get it and also modify it according to your needs in that specific country.
Thank you so much, Dr. Julieta. So Dr. El Hadi is actually an OBGYN from Sudan. So, you know, he's not too far away on the continent from you.
Well, Shilpa also had a question. So let me see if I can get Shilpa to unmute. Perfect. Why don't you ask your question? Thank you.
Thank you. My question was, how was the subject of mental health, maternal mental health, especially accepted as a public health problem by the community health workers in your setting? Was there any denial in the beginning? Because at times we have seen that more than the community, it's also the health workers themselves who are in the denial mode in the beginning to accept such problems, especially in the maternal population. Thank you.
Yeah, thank you, Shilpa. I think it's a very, very relevant question because at one point our Prime Minister addressed the International Mental Health Day on the 10th of October, and she said it doesn't matter how many people are present at the event that day, as long we are starting somewhere. So we still have a long journey to go and let everybody understand what mental health in general is and to scale down to maternal mental health. The health workers have been pinpointed as culprits of the most stigmatized, because when somebody comes at the facility, you are not even called by your name any longer. It's saying it's a schizophrenic that came, or it's a bipolar that came. So I think it's very, very difficult that the understanding on what mental health is and how the stigma and discrimination and the whole treatment of people with mental illness with mental illness are being treated even at our health facilities. It's a big concern. But one, it's never losing hope to educate, to advocate, because when I was a deputy minister, everybody was saying that this is the first deputy minister that is talking about mental health. Why are you so much concerned about mental health? I say you go to areas where nobody was, and it's where you make an impact. Because when they are looking at you, at your portfolio, and that you are talking for something that is never talked about, I think it actually make people to start understanding that there is a serious issue that need to be addressed. So it's still a long way to go, but we are hopeful and positive that we are going to overcome this battle of the marginalization of mental illnesses and mental health in general. Thank you.
Thank you so much.
Thank you so much, Dr. Julieta and Dr. Shilpa from India, who also is one of our past webinar presenters. So wonderful to see you here, Dr. Shilpa. Dr. Julieta, I have a question for you. I've lived in Nigeria. I think you know I was born in Kenya. And one of my observations in rural Nigeria especially was seeing how people were so supportive of each other. And they would sometimes say, oh, so-and-so has a mental health concern. but still lovingly involve that person in all their activities. So I found in many ways that the cultural norms were able to get over some of the mental health stigma. So yeah, I'd just like to ask you about how in Namibia, does the community support and the way in which people care for each other, does it somehow act as a way of buttressing some of the mental health concerns?
Yeah, thank you very much, Dr. Farah. I think the most important thing is that at one point, all of us are part of the statistic, because 1 out of 5 we are suffering from the mental health. In our lifetime, we will suffer from the mental health, or will be diagnosed with it. So that aspect, the caring aspect in an African setup, is actually a natural thing. But there are things that make it so difficult, because many people believe, the same people that are so caring, they actually believe in that mental health can be a curse, it can be an issue God is punishing the family with, because your great-grandmother have done something wrong. It's never a disease as we understand it in a European way or in another platform. So many, even in our cases, while the person is on treatment, they can be left on treatment. Somebody can tell them that, no, don't drink the tablets because they are very addictive. They can actually, they are having severe side effects, but we can give you a witch doctor in order for them to heal you. So I think there is actually a paradoxical attitude today. While we are caring for our people, there is also another component of rejection because of myth and misunderstanding of the concept. So it's why with our community mental health concept that we want people not to be admitted, because when they are admitted, it's where, unless there is an acute or an acute episode where you cannot handle the person. But the other people that are on treatment, that are having chronic diseases, we want that are chronic, that are having chronic diseases, that are on treatment, we want them to be supported from home. Somebody from the family will go with the person to the facility and take the medication and know how to take it, and know when the episode is supposed to start or when the person doesn't take medication. So I think it's a very, very delicate issue, that there are people that really love their people, but when it's even mental health issues, when there is a serious episode, then they actually distance themselves. Then we had a case of a man, an executive in the government, the second highest position in the government. But when he is having an episode, even his own family, the wife and everybody was actually ashamed to talk about it. So we think that there is some underlying issues that need to be brought to the table in order for us to accept mental health and treat it as like any other disease.
It's so true. Dealing with the stigma is the #1 issue to preventing people who need the care from actually receiving it. Thank you for that. We do have a question. Anne Revington would like to ask a question, and hopefully you were saying something about your internet connection. So to have a go.
Okay, can you hear me?
Yes, perfectly.
Am I live? Oh, great, right, it's working. Hello, Dr. Kuana. It's so nice and so refreshing to hear your enthusiasm for postnatal care, because in the West, it's really, you may probably most likely know, it's known as the black hole of healthcare because of the lack of support and the lack of recognition of what goes on. This is why, from an Ayurvedic point of view, we're so enthusiastic about caring for mental health through our approaches too. And I just wondered whether you've had any exposure to Ayurveda in Namibia and what your thoughts on it are.
No, I couldn't hear the last part.
Oh, she said she asked you if you had had any exposure to Ayurvedic medicine, which is very much linked to yoga. So maybe she didn't hear you talk about the yoga part. You're already incorporating yoga, but she's asking about Ayurveda and if there's been any exposure in Namibia to this system of medicine, which comes from India, the oldest recorded system of medicine in the world, Ayurvedic medicine.
Oh, no, I'm not familiar. Maybe unless I have to ask around, but I never heard about it.
Ah. Yeah, maybe we can do a little bit more talking, because there is so much to offer from Ayurveda for postpartum women, just helping them get back physically and mentally into balance. It's very, very beautiful, and it's not expensive.
Wonderful. Sounds like maybe we'll have to add in another lecture in the near future where we touch on Ayurveda. And I mean, we have some that we've been talking, but maybe in the future we're going to add in another one, and everybody can tune into that. So let's continue with our next question. Could you please explain more about the reasons that infections account for such a significant portion of the health problems? Does this also include sepsis for birthing mothers?
Yeah, I think that there is a whole a discussion about the issues of infections and the mothers and the deliveries and a lot of sepsis, you know, in the facilities. There have been a research by one of our top ops and gynae who had the near menses issue of the whole maternal issue, that have really gave bad results in terms of the figures of people that are dying in terms of having been infected, developed some sepsis during delivery or after delivery, especially those ones that are coming from the rural area. But statistically, there is nothing that have been recorded so much. It's just that maybe it have been reported at a very informal level that there is a lot of an increase of infections and sepsis for after deliveries for many, especially the older women who had already multiple deliveries. They actually suffer from a lot of sepsis. So there is no really just a clear discussion about it. It never took place at a platform, but I think it need to be. I know that one of the experts in maternal issues have been saying we need to have a model, or actually also a policy on how to treat people that not to get infections after delivery. There is also a lot of infections or sepsis that develops, especially because of abortion. It's not legal in our country, and most of the young people are doing bush abortion. When they come to the hospital, it mostly become too late for them to be assisted. So, and that have created a discussion. Currently, the parliament is having two petitions from the pro-life and from the pro-choice groups that want abortion to be legalized, and the others that are opposing it on religious grounds. So, and they are publicly hearing it for the first time. We had two petitions that are actually countering one another. So, but the issue of not well-treated miscarriage, in brackets, abortions, it's really a concern in our country.
Yeah, unfortunately, that is the conversation that is happening around the world in many places, including the United States now, sadly. I think, Dr. Schroff, did you have a question you wanted to ask?
Yes. Dr. Kavatuna, thank you so much for all this wealth of information. I'm learning so much. And I wanted to touch on the gender-based violence that you talked about. You talked about it quite a lot. You said that there was quite a lot of gender-based violence, mainly rooted in poverty. And so I'm wondering about the PTSD, which you talked about later in your presentation, and how gender-based violence causes PTSD, and that's very. I'm wondering what's the relationship with that to childbirth and then postpartum depression and anxiety.
I think the most violence that are happening here, and it's actually, as you have said, in terms of cultural values and other things that we are actually mostly hiding behind. There is a lot of incest that are happening. Then there is number of rapes of underage and very vulnerable women. Even in families, I think that patriarchal attitude of men is still overshadowing the decision when to have a child or not to have a child. So many people might not even use contraceptives because their husband doesn't want them to do it, but then they have up to 7 children that they cannot afford for, and it's becoming a problem to them. So the gender-based violence, whether it's physically, psychologically, mentally, I think it's actually very, very real in this part of the world or in our country. And it actually contributes so much to post. Just imagine if you have to have a 7th child, but you cannot even look after the 6 that you are having. And also this thing of men are not able to provide for families. Single mothers headed homes are on an increase. I think we were last at 45% of houses that are actually, and the absent present husbands that are also another issue. They are just husbands in terms of laws, but no presence at home. So I think the gender-based violence, it's really not the most physical one, it's actually happening with femicides and other things that are happening, but there is also a very huge component of psychological, monetary and mental abuses that are going on because of the illiteracy, because of poverty, because of other things. And this actually contribute to and it's why we actually at our center, when we were making this proposal, our issue is that how do you treat a woman who does not know, whom you doesn't know what is her problems? So there is nobody who cares, you know. You just come for antenatal care, we finish, but then after 5-6 months there is an abort and a miscarriage or the baby is lost. But that what could have been the issue, the underlying factors that we really want to make sure that how is it impacting when you actually have these women from the onset and you cancel them, and what is the result of the person who was never cancelled or who was never referred. So that's basically the whole concept of this perinatal care integration in maternal mental health, in maternal mental health, in perinatal care.
Dr. Solomons, may I ask a follow-up?
Absolutely, absolutely.
Thank you so much, Dr. Julieta, for that really fulsome answer. And what it really takes me to is the ways in which we take these big social problems at the way they manifest clinically, and the only solutions we have are clinical, one-to-one clinical care. But clearly, addressing the social determinants of maternal mental health involve looking at all of these large structural issues: violence against women, poverty, housing issues. All of those issues, if addressed, could lead to such a sharp reduction in mental health concerns generally that we wouldn't need all the clinical care. And we never, in any part of the world, ever have enough clinicians to deal with mental health problems. In the United States and Canada, less than half of the people who need mental health counseling get it. It's always in short supply. And so we have really failed to look at the variety of other ways in which we as a society can treat mental health conditions. And so I just love to hear you talk about that. Like, I think, so if we were still to look at the therapeutic ways, there's dance therapy, there's talk therapy, which we use a lot, cognitive-based therapy, play therapy, yoga therapy. There's so many forms of therapy that aren't used, but we're still not really getting to the structural roots of the issues. Like, it needs a whole package of treatment. And I will stop there. So please go ahead, Dr. Giulietta.
Yeah, no, I think you actually just said it correctly, 100% in an agreement with you, that is just one component. The main factors are actually social ills that are still hanging around there. Unemployment, poverty, lack of food. There is so many things that need a comprehensive approach in order for us to have the better results and reduce maternal mortality, or even the well-being of women in general. So I actually totally, I don't want to dilute what you have said. I think I actually agree with you in 100% in that regard.
Well, it's so wonderful to hear people in Parliament and people in those roles. So many times it's always about a kind of a reactive symptom fixing, just talking about deaths or just talking about hospital treatments and physical health. So it's so refreshing to be able to hear someone who really recognizes the big picture and recognizes all of the other things that need to happen. So thank you. That it's really refreshing to hear. So I'm just looking at any of the last questions. So I think we did talk a little bit about, besides counseling medications, what you were doing, and you talked to, do you have any other, besides counseling and medications, were there any other major forms of care that they are doing in Namibia?
I think there is some care that integrated also within the health system, especially when it's coming to mothers, because of the high rate of HIV. They actually have integrated a care for, because for instance, if the mother is found HIV positive, the next visit you have to bring the husband or the partner along. And that helps with the identification of people and enrollment of people on ARV. So I think it's one best component. It's a good model that we actually have succeeded in doing, because in many instances, as I have said, that there is so many things that are left outside, that women are having children out of wedlock. Just to bring a partner along to the facility, I think it's a battle uphill mountains that one has to climb in order to get that person to the facility. And I think it's really a commendable effort and a very big effort that women does, and what the ministry is also. So the men, if you tested positive also, then they get a counseling together, and closer to the delivery, the woman is getting the Verapin in order to save the child's life. The mother and father can be HIV positive, but then the baby is HIV negative. So it's one of the models that Namibia have really stick its head in terms of combating or reaching the 95, and we are already somewhere in another area, 96. Thank you.
That is wonderful. Well, I think we've actually come to the last of the questions. Farah, did you have any more? Dr. Schroff, anything else you wanted to mention or ask?
I just wanted to say what an absolute pleasure it was to hear Dr. Giulietta, somebody with so many different roles in your country, Dr. Giulietta, the fact that you've been a parliamentarian, you're a healthcare worker, you're an activist, and you speak with such clarity and authority and passion about women's health issues. I'm so grateful to you for the work you're doing. Thank you.
Agreed, 100%.
Thank you very much for your time and the platform that you gave me. it's really a great honor that we actually cross our ways and you could manage to give me this opportunity. And I think I have a long way to go. And I want to become the African yoga instructor in your own behalf.
Yay, that's next.
Yes, I think in the future we have a lot of overlap that will happen. So we'll hopefully be able to all stay in touch, and many projects on the way, many projects. Yeah, everybody, if you want to put on your screens and show your faces as we say goodbye, it'd be so wonderful to see everybody. Yes, hello,
Dr. Ahadi. Hi, Shelley.
Oh, Prof. Farah, how are you? Fine.
I'm very well. Nice.
Thank you for the organizing committee. It's really very interesting. Thank you very much. Thank you.
Thank
Hi.
you. Yeah. Thank you, everybody, for coming. It was so great to have you all here.